Deputy Mayor. Vincent Calamia. Dr. Calamia.
Yeah, I just actually caught the sound for the first time now.
Okay.
Excuse me.
Yeah.
Jose, let's start over. Apparently the sound did not work from us.
Yeah.
Let's start over. Let's.
So it's going to work the next? Yeah, okay. So, okay, I'll start again. Okay. So welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. Please note for the record that Dr. Michelle Morse is representing Dr. Ashwin Vasan in a voting capacity. So next on the agenda is the adoption of the minutes for the board meeting held February 24th, 2022. Are there any questions, comments, or changes? So hearing none, can I hear a motion to accept the minutes?
So moved.
Let me check on the votes quickly. Dr. Katz?
Yes.
Deputy Mayor Ann Williams Jason?
Yes.
Dr. Calamia?
Yes.
Dr. Martone? Dr. Morse? Dr. McRae? Thank you. Gary Jenkins? Barbara Lowe? Robert Nolan?
Yes.
Rita Wang?
Yes.
Benioski Peña Mora?
Yes.
Ananita Kawatra?
Yes.
And Jose Pagan, yes. So the minutes are approved. So during the executive session, the board received and approved oral and written governing body submissions from NYCHNH Gouverneur and Kohler Long-Term Care and Rehabilitation Center. The board received and approved semi-annual governing body reports. These are written submissions from NYC Health and Hospital Woodhull. And then during the executive session, the board unanimously confirmed their support for Dr. Mitchell Katz's continued service as president and CEO of NYC Health and Hospitals, as recommended by Mayor Adams.
Thank you.
Congratulations,
All right.
Dr. Katz. Okay. So, standing committee appointments. According to Article 6, Section C of the bylaws appointment, the chair of the board shall annually appoint, with the approval of a majority of the board, members of the board to a standing committee. So I would like to propose a motion to appoint Dr. Ashwin Vasan to the Executive, Equity, Diversity, and Inclusion, Governance, Quality Assurance, Performance Improvement, and Strategic Planning Committees. All in favor, please say yes.
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 Opposed say no. So Dr. Vasan, you have been appointed to many important committees. Thank you so much for your service. Since we began the process of approving contracts prior to VENDEC approvals, there are 18 items on today's agenda requiring VENDEC's approval, of which 16 have the approval. There are 9 items from previous board meetings pending VENDEC's approval. Since we last met, no approvals were received. We will continue to notify the board as outstanding VENDEC's approvals are received. So let's now move to the resolutions. Let's move to item number 3 in the agenda. So Dr. Calamia.
Thank you. Authorizing funding for New York City Health and Hospitals Corporation, the system, to continue to operate under the terms of affiliation agreement with Physician Affiliate Group of New York, PC, also known as PAGNY, made for the provision of general care and behavioral health services for a period up to 3 months with the system facilities served by PAGNY, to include Lincoln Medical and Health Center, Morrisania Diagnostic and Treatment Center, Segundo Ruiz Valdez Diagnostic and Treatment Center, Jacobi Medical Center, North Central Bronx Hospital, Harlem Hospital Center, Renaissance Healthcare Diagnostic and Treatment Center, Metropolitan Hospital Center, Coney Island Hospital Center, and Kings County Hospital Center, with an overall cost of the extension not to exceed $187,805,542, which does include a 10% contingency. This is being presented as a motion to the entire board directly.
Good afternoon. Thanks for having me. Yes, we continue to make rather significant
progress with PAGNI on the full extension, and it's our hope that we'll be back here in April, with that proposal for the board. We do need funding authorization to carry us through the next 3 months, to get us to the end of the fiscal year for us. The next slide shows, the history of the authorizations. Down at the bottom, you can see that it's a straight 3-month extension. Total value is $187.8 million. We do note down below that we did dip into the contingency, and we've outlined the reasons for that. COVID-19 spending was a big driver. We made the decision during Omicron that we would lean more heavily on our own physicians rather than seeking outside locums. We enhanced sessionals. There's also a plan underway for us to move physicians from health and hospitals on a voluntary basis over to PAGNI. So that's just really a movement of dollars from our budget into the PAGNI contract. And then we have ongoing efforts and initiatives underway that require additional physicians. Those physicians in our part of our business planning process, we think would generate more revenue for health and hospitals. So that's our request. It's a 3-month extension to carry us through June 30th.
Thank you so much. Any questions from board members? Frida?
Okay, could I just make one clarifying? Could you go back one slide, please? Just the amounts that we are eating into the contingency, sort of, more than what we might have expected in terms of budget. Those amounts, if I'm reading the reasoning and what you just mentioned, John, appropriately, that it's not really an increase in expenditure, but sort of a shifting of budgetary items or else offsetting revenues that we expect to have, whether it's fee reimbursements or revenue generating businesses that will cover those increased costs that are eating into the contingency. Is that correct?
Yes, that is correct.
Okay, great. Thank you. Just wanted to clarify.
Yes.
Thank you for the clarification. Any other comments or questions? Okay, so I would like to then ask for a vote on this. Dr. Katz?
Yes.
Deputy Mayor Ann Williams Eisen?
Yes.
Thank you. Dr. Calamia? Dr. Martone?
Yes.
Dr. Morse?
Yes.
Dr. McRae? Yes. Gary Jenkins?
Yes.
Barbara Lowe? Robert Nolan?
Yes.
Frida Wang?
Yes.
Dr. Peña Mora?
Yes.
And Anita Kawatra?
Yes.
And Jose Pagan, yes. So the resolution is approved. Thank you so much. So let's move to the next one. I don't see Sally. Yeah, Ms. Pinheiro. I'll do this one then, the next one. And this is an amendment from the audit. There's an amendment from the audit committee presentation to change the terms from 2 years to 2 years and 2 months, and to clarify the contract amount of a contingency for a total NT value rather than inclusive of contingency, and clarify MWB percentage to be consistent of 25% in the resolution and the presentation. So the resolution is authorizing the New York City Health and Hospitals Corporation, the system, to execute a 2-year plus 2-month best interest contract extension with Grant Thornton LLP, the contractor, for auditing services in an amount of $1,931,500 plus contingency not to exceed a total value of $2,019,500. And this was presented to the audit committee March 22nd, 2022.
That is true. So, thank you. My name is James Linhart. I'm the Deputy Controller. I'm here with Jay Wyman, who's the Corporate Controller. And we're here, she read the intro, which we're seeking a 2-year plus 2-month extension for auditing services with our current audit firm. Right now, As it stands, the financial statements must be audited by an independent certified public accountant. It's required by our corporate bylaws, our PAAA standards for bond issuances. Plus also the reimbursement department issues cost reports, and the cost reports need to be certified as well, some of them at least. So the current contract vendor, as I said, was Grant Thornton LLP. The contract was procured through an RFP in 2018. The contract term was for 4 years and expires on April 30th, 2022. That's why we're requesting the 2-month extension to align ourselves up to the city contract, which begins July 1st. So that's 2 years and 2 months. The previous spend with Grant Thornton last year was $924,100. The 2 years that we're adding on, or we're asking to add on, FY22 is $951,700, and FY23 is $979,800. Next slide, please. Thank you. As I said, the reason for asking for this extension is so we can align ourselves up to the city, so we could be included within the city contract for audit services. One audit firm would be the best approach, we feel. And as I said, it was a 2-year, 2-month contract extension for a current not to exceed value of $2.019500. And this is needed to align to the city contract, and this is in lieu of issuing an RFP for this 2-year extension. Next slide, please. Now, the rationale for the extension. We believe that we have better negotiating power given the size of the current city contract. There'll be ease of meeting the stated deadline since New York City H&H will be part of the city's publication. An easier flow of information between the 2 accounting firms, or the 2 accounting teams, I should say, being that they're one firm. The advantages is that we will still retain autonomy of audited services, and we will still issue separate financial statements. Our audit committee will still retain the right for review and approval of the financial statements. We will have representation on the city's RFP once that comes around in 2 years. And we will also continue to maintain our CPE credits, which is continuing professional education credits that we, in the past, have asked the accounting firms to pay for on our behalf for our staff. Next slide, please. Continuation of the background. The price has not increased significantly in the past 8 years. We've been to RFP twice. Review of the contract extension fees for FY22 and 23, as I said, was $951,700 and $979,800. That's exclusive of the contingency that I built in. And as you can see from the slide, those two amounts for 22 and 23 are actually lower than some of the years that we previously paid. 13 and 18 at $994,300 and 19 at $994,300. I'm sorry, 13 at $994,000. Next slide, please. So this is a satisfaction survey. There's 12 questions here. We responded yes to all of them, and we're very satisfied with Grant Thornton. We gave him an excellent rating. Next slide, please. This is the MWBE slide. Grant Thornton is committing to a 25% usage of MWBE contractors during the next 2 years of the contract extension. And this slide tells you what firms they're going to be using: Chang and Healthcare Management Solutions. Next slide, please. So overall, we come to you seeking approval to extend the contract with Grant Thornton LLP for 2 years and 2 months, expiring June of 24, for a not to exceed value of $2.019500 in order to align ourselves up to the city contract and participate in the city's RFP, which they'll be issuing in 2024.
So this Jay Wyman, Corporate Controller. I just want to add a couple of comments here. Is that, we have our own audit. We are also part of the city's audit, right? So their financial statements include us as what they call a component unit. We are one and the same within their financial statement. But we have our own because we have a separate corporation, separate guidelines governing us. So this is really just to have one contract so we could align ourselves within the city and communicate a little bit better. It doesn't change one thing about the audit. There'll still be a healthcare, financial audit for H&H. There'll be the city's audit. There'll be 2 separate teams. So I just want to make sure that, that I got that out, that 2 separate teams under one contract. And that's what we're seeking here to get approved.
Thank you so much for the presentation. Are there any questions from board members? Frida Wang?
Jay, could I just, on that point, and I saw that James said the H&H will have representation in the RFP committee. If it comes to pass that, what's best for the city's audit and what's best for H&H wouldn't necessarily be the same auditing firm, we're still able to go retain our own on separately.
Of course, yes. Of course, and this gives us the flexibility. What it does do is whether we go with their auditors or not, it will forever keep us on the same path and the same timeline, and we could do that in the future if we wish. So, but we can never do that until we get aligned with them, and that's really the purpose of this extension.
Okay, great, thank you.
Anything else? Any other questions or comments? Okay, so then let me move to a vote. Dr. Katz?
Yes.
Deputy Mayor Ann Williams Hyson?
Yes.
Thank you. Dr. Calamia?
Yes.
Dr. Martone?
Yes.
Dr. Morse? Dr. Morse? Dr. McRae?
Yes.
Thank you. Gary Jenkins?
Yes.
Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Frida Wang?
Yes.
Benioski Peña Mora?
Yes.
And Anita Kawatra?
Yes.
And Jose Pagan, yes. So resolution approved. Let's move to the next one. Thank you. Thank you, James. Okay.
Thank you.
Frida, this is yours, number 5.
Is this universal? Okay. Authorizing the New York City Health and Hospitals Corporation, the system, to execute 3-year standby or requirements contracts with each of Universal Protection Service, LLC, doing business as Allied Universal, Johnson Security Bureau, Inc., Maxi Building Security and Management Corporation, and Aaron Security, the contractors, for temporary security services with the system, holding 2 one-year options, an amount for all the contractors across the entire potential 5-year term, not to exceed $11,600,000. And I think this was approved at Finance Committee to bring forward to the full board.
Thank you so much, Frida. Good afternoon, everyone. I'm Eric Way, Chief Quality Officer for Health and Hospitals. I'm joined here today by Juan Teco, our Chief Security Officer. And also, this RFP was done with the support of Christine Clarity and Danielle Tabari's teams. So we have hospital police across our system, as you all know, but we have historically been challenged with fully staffing all of our vacancies for hospital police, and therefore we've relied on agency support to fill some of that staffing gap. This also applies to security at central office, so for 50 Water. But I'm going to tee it up and hand it off to Juan, who will take us through the RFP, and then happy to answer any questions. So Juan?
Hi, everyone. Good afternoon. So New York City H&H has used supplemental security staffing firms to augment staffing needs at acute, post-acute, Gotham, and test and trace facilities. The services have been provided by Universal Protection Services, LLC, and Johnson Security Bureau, Incorporated, and include unarmed security guards, security guard supervisors, fire watch personnel, and fire safety director services. These services have been coordinated directly between the facility and vendor and are meant to supplement security services shortages. Estimated annual spend, $2 million. Current titles provided: security guards, dual certification to include fire watch personnel, security guard supervisors, and fire safety officers. Cost structure for this charges are based on hourly rates for each title to meet prevailing wage, plus administrative fee. Services can either be provided on immediate need or by predetermined SOW. On 10/22/21, RFP posted on city record, sent directly to 29 vendors. On November 9th, 21, pre-proposal conference held, 15 vendors attended. On December 1st, 2021, proposal deadline, 9 proposals received. On January 27th, 2022, evaluation committee completed scoring sheets and submitted to supply chain for tabulation. On February 14th, 2022, evaluation committee finalized vendor pool, Universal Protection Services LLC, Johnson Security Bureau Incorporated, Maxi Building Security and Management Corporation, and Aron Security, also known as Arrow Security, were the highest rated proposals. Are there any questions so far? Just wanted to kind of pause there.
No, go ahead and finish, and then we'll have questions at the end. Yeah. Thank you.
Maxi Building Security and Management Corporation is an MWBE corporation, successful reference check with Project Find, long-term healthcare, long-term home health organization. Maxi provided rapid response time and performed satisfactory. Successful reference check with ACMH, Care Management and Housing Organization. Maxi provided appropriate capacity, rapid response time, and performed satisfactory. Aron Security, DBA, Arrow
Juan, I
Security.
don't think we don't have to read all of these bullets, but we just say
Okay.
that we, check the vendor
Check,
references,
Yeah,
which are
we
listed
did.
here. So, yeah.
So we checked
you.
Universal Protection Services LLC and Johnson Bureau, which is also a WBE. The RFP criteria, minimum criteria, MWBE, number 26.
Go to the next slide. So this is standard criteria.
Yeah. So out of the 4, 2 are WBE, MWBE certified. You have Maxi Building Security and you have Johnson Security. Universal Protection is 30% and Aron Security is 30%. Hospital security updates, staff debriefs, and town halls following Jacoby incident, including review of prior safety and workplace violence mitigation initiatives, sharing lessons learned from Jacoby and the after action report, site visits to health systems and surveys of New York City hospitals and safety net hospitals in other cities were also contacted. Actions taken, installation of direct tie line from each phone, additional visibility mirrors, bulletproof glass, and central work groups, metal detectors, NYPD paid detail, which is right now a courtesy of the 4-9 precinct, hospital police recruitment and retention, active shooter training, facility-based security risk assessments have been done, review of Everbridge system, and review of panic alarm systems. Board of Directors requests. The Office of Quality and Safety is seeking approval to award contracts to Universal Protection Services, Johnson Security, and Maxi Building Security, and Aron Security to provide supplemental security staffing services to the system. 3-year contract with 2 one-year options, exercisable at the discretion of New York City Health and Hospitals. not to exceed 11,600,000, effective May 1st, 2022.
Thank you so much. Are there any questions from board members? Okay, hearing none, then let me then ask for a vote on the resolution. Dr. Katz?
Yes.
Deputy Mayor Williams Ison?
Yes.
Dr. Calamia?
Yes.
Dr. Martone?
Yes.
Dr. Morse? Dr. McCray?
Yes.
Gary Jenkins?
Yes.
Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Frida Wang?
Yes.
Benioski Peña Mora?
Yes.
Anita Kawatra?
Yes.
And Jose Pagan, yes. So the resolution passes. Thank you so much, Eric, Juan. Thank you. So let's move to the next one, number 6 on the agenda. Frida?
Okay, authorizing the New York City Health and Hospitals Corporation, the system, to execute a 3-year contract with Care Solutions, Inc., the contractor, for outpatient coding and billing services, with the system holding 2 one-year options for an amount across all potential 5 years of the proposed agreement, not to exceed $12,491,383. This was approved at Finance Committee last week to be brought to the full board.
So, good afternoon. I'm Bob Melican. I'm here with Ua Muin and Margie Carlin to present on our coding and billing RFP we recently conducted. To frame this RFP within revenue cycle, H&H produces 2 types of claims, a professional claim and a hospital claim. The professional claim is for services performed directly by the provider, and they're billed separately. Professional claim follows a completely separate coding and billing rules. Even in Epic, it's a separate module. H&H earns $32 million in revenue from professional billing, very small compared to our institutional revenue, but nonetheless a vital component. H&H claims for the institutional portion of the services, the regular bill we're all familiar with, the inpatient, the ambulatory surgery, the emergency room. We bill and code for those. But due to the high volume of outpatient encounters, H&H requires vendor assistance to code. This contract will provide that outpatient coding service. H&H is looking to reduce its coding volume through technology, but we do require assistance with coding at all hospitals. In short, this contract is for coding and billing professional claims and coding the outpatient claims at all our hospitals. Vendor support for professional coding and billing is only needed at Bellevue, Kings, Queens, and Woodhull hospitals, those without a faculty practice. Our RFP timeline, we released the RFP in May, and we had 2 components, to that RFP, a coding and a professional billing. Each component had a separate committee, and it was scored separately. All but 1 vendor submitted for both components. We received 7 bids for coding, 6 for billing. After an initial round of scoring 3 vendors, were invited for presentations, and then the final 2 vendors were invited back again for a 3rd round of question and answer. Both evaluation committees selected Care Solutions as the highest scoring vendor, our current incumbent. In December, the contract review committee approved Care to move to the full board, and we were approved for here. So I want to turn it over to Ua to run through the details on the RFP process.
Sure. So here's our RFP criteria and our minimum requirements. They must have an MWBE utilization plan or certification, 5 years experience in New York State Medicaid experience for coding and billing, and they need to have coding experience in Epic, and their annual revenue has to exceed $25 million. We were looking for a large vendor that covers the New York State in our applicant pool. What takes priority for us is knowing our vendor can handle, 1, our New York City Health and Hospitals coding requirements, and 2, they can handle our large volume. And below is how we rated all the vendors who bid. So 40% cost, 30% quality of proposed operational approach, and 30% for both MWBE and quality assurance. Oh, wait, what? Okay. And to the right, you can see our evaluation committees for both billing and coding. It was made up of accounting directors, HIM directors, 2 CFOs, EITS, and a compliance officer that work at the locations on the left of the chart. And we wanted to make sure the committee mirrored the folks that use Epic on a day-to-day basis. All right, next slide. So right now, we're making sure that Care
Thank you so much. Any questions from board members? Okay, so hearing none, let me then ask for a vote. Dr. Katz,
Yes.
Deputy Mayor,
Yes.
thank you. Dr. Calamia,
Yes.
Dr. Martone, Dr. Morse, Dr. McCray,
Yes.
Gary Jenkins,
Yes.
Barbara Lowe, Robert Nolan,
Yes.
Rita Wang,
Yes.
Dr. Peña Mora,
Yes.
and Anita Kawatra,
Yes.
and Jose Pagan, yes. So the resolution is approved. Let's move to the next one. Thank you so much.
Thank you.
Which is number 7. I think it's you again, Ms. Wang.
Me again. Okay.
Yes.
Authorizing the New York City Health and Hospitals Corporation, the system, to execute a 5-year contract with UKG, also known as UKG, for managed payroll services with an advanced scheduling application for an amount not to exceed $33,421,438, including a contingency of 10% or $3 million. This was presented to and approved at the Finance Committee meeting on 3/22/22 to come before the full board. Thank you.
All right.
Thank you.
Hi, Jay Wyman, Corporate Controller. So the payroll service has been traditionally performed in-house, and so is the scheduling system, which we use, Clearview. The payroll system is an old mainframe system, which we describe as over 30 years old. It is very hard to maintain, requires significant investment to keep it going. And the scheduling system which we currently use, Clearview, doesn't have all the adequate reporting. It's not user-friendly, and it really limits the users to do their job. Next slide. What we're looking to do is on the future state, the future state would look like, payroll services would be managed by UKG. That's what we seek in this resolution. Advanced scheduling would be managed by H&H using UKG software. And this is what it would look like in terms of time and attendance. All these modules would be mobile capable, so people could use it on their cell phones. Real-time punch data, as opposed to uploading data in not real-time. Employees can request time off. Employees can attest to time, meal breaks. On the managed payroll service, UKG would provide all the on-cycle and off-cycle payrolls. They would do all the payroll tax filings, which we currently do in-house. They would conduct the year-end close management, including the W-2s, and they would maintain an employee contact center for our employees to call. For advanced scheduling, currently Clearview is really just a nursing-only tool. UKG provides a service that we could open it up to other departments and available for that, also mobile capable. The visibility of staffing could be in real time, and it's integrated with Epic data, so we get patient assignments with workloads imported into the system. In terms of data and analytics, over 800 reports, real-time access, We could build our own key performance indicators. And of course, at any time, we could add reporting capabilities whenever we want. Turn to the next slide. Thank you. This is our procurement. Back in September, we issued an RFP. We decided to issue it for both the scheduling system and for payroll. In November, we started to review evaluations, conduct demos. There were 4 proposals received. 3 included both payroll and scheduling. And in January, in both scoring rounds between scheduling and payroll, we picked UKG unanimously.
Thank you. Hi, my name is Tatiana Seta. I'm Deputy Controller. The cost of the vendor contract is split between the implementation cost of $2.5 million and ongoing subscription fees of $7 million a year. A 10% contingency is included. The total 5-year value of the contract is $33.5 million. Our current in-house cost of running payroll is $36.80 per employee per month, which includes both the personnel and non-personnel costs to manage our 40-year-old payroll system and provide support to our employees and managers. Transitioning to a new system will allow us to bring the direct cost of payroll down to $19.50, almost half. And in addition, we will transition to a new time capturing technology, and that will allow for accurate time, which Deloitte estimated that this will reduce our costs further by $15.50 per employee per month. For RFP, minimum criteria, 10 years in business, MWBE, experience with large health systems that operate in a unionized environment, preferably in New York. Selection criteria included functionality cost, strategy and timeline approach, and MWBE. Responses to the RFP were reviewed by 2 committees, one focusing on managed payroll services, the other on the advanced scheduling solution. Members included cross-functional representation from facility and central office leadership. UKG formed as a result of a merger between Kronos and Ultimate Software. They're market leader in human capital management, as well as healthcare industry with 3,500 hospital and 10,000 post-acute care clients. Their systems are well known in the healthcare industry and are used in many of the large health systems in New York City. In addition to the software solution, they will provide experienced, dedicated onshore support to act as an extension of the H&H payroll team. Positive feedback was received from references at Northwell, NYU, and NYP. Out of the 10 vendors that were invited to participate in the RFP, 6 were MWBE vendors. None of the 6 responded to the RFP. The only area where UKG is able to subcontract is the client-side implementation support, which represents roughly 30% of the $2.5 million implementation costs. And that service includes helping our team migrate historical data into the new system, provide change management support, and process re-engineering that we may want to leverage. The rest of the services are provided by UKG as part of their software as a service model and cannot be subcontracted. Our current process for MWBE is to analyze this procurement for MWBE availability and capacity, and then set a goal based on that analysis. That goal can be from 0 to over 30. The UKG procurement went out the door before we established the goal-setting process. Our default goal was 30%. We likely would have set a goal much lower under our current policy and process. Throughout this transition, H&H is committed to supporting the impacted payroll staff and ensuring they are redeployed to alternate position within H&H after the system implementation is complete. All impacted staff and their unions were notified of the transition in advance of the RFP being issued last fall. There's ongoing training and change management support provided to the staff that includes regular meetings, status updates, sharing of opportunities for training, as well as job opportunities. The new system implementation is expected to take 15 months with a projected go-live date of July 1st, 2023. The implementation will begin with a detailed planning phase, followed by system design, system build, data conversion, testing, and deployment. The payroll system will go live as a big bang, whereas advanced scheduling will have a multi-phase deployment with nursing going live first. It is expected that the transition of the payroll staff to alternate positions outside payroll will take at least 6 months post go live. And that's it.
Okay, thank you so much. Any questions from board members on this resolution? Dr. Peñamora, go ahead.
Hi, thank you. Again, thank you for the presentation and definitely this particular procurement is going to really enhance our payroll and our systems and bring us to the modern era. But I do have a question, mentioning the inability for this contract to have meaningful MWBE participation. Have we had discussion with this vendor in terms of how they are positioning their supply chain and their ecosystem in order to increase participation? Because we have seen how even the New York Stock Exchange is asking now a listed company to provide ESG reports. Of course, a lot of emphasis sustainability, but the issue is also on, equity. So I think it will be good to understand how this company is performing in those measures. And also, there was a comment that you mentioned that for like some procurement, particularly this procurement, you may have to set up lower goals for MWB. Can you elaborate what you are thinking about for the future?
Yeah, let me try, Jay Wyman. So the default was 30% goal. That's where we started with. This is before we understood how the UKG model was and how they delivered the service. Had we known the type of service, most of it is a SaaS model, which is a cloud-based service. It's, the technology, the security, everything is managed by them. So, we didn't know much about it when we sent out the RFP. We learned a lot. Had we known how the service was operated, we probably would have had a much lower percentage, because the only part of the service that they have that they would utilize a contractor services, the implementation piece. And the implementation piece is a smaller piece of the pie. The rest of it is actually managing the service itself. So that's what Tatiana was talking about, the 30%. But that was the default, and we realized that could never be met.
Okay, but just to be clear, because I can see the problem. We don't want to suggest, it's not that we're making any decisions about being less assertive about increasing the proportion of women-owned and minority-owned businesses. What you're saying is that we set the 30% goal, which is what we always want to achieve at least or exceed. It's true that we learned in the process how few vendors there are who are at this level. So I don't want anyone to think that we're changing our standards or going down. I think what you're saying is that we had hoped that there would be a MWBE vendor, somebody who would be able to do this job. Fenny, though, is asking, I think, a very thoughtful other question that we should talk about. We negotiated an increase in their MWBE participation from what they had proposed. So initially, they, like the other providers who bid, didn't propose anything. We negotiated up, and we got them to agree to do something that they didn't propose. What I hear, and Fenny, I think is right, is, okay, but what's the future, right? Like, how as a company, it's not about what they can do at this second, because there are constraints on licensing, there are constraints on who is an eligible provider, but what can they do so that when we're bidding a payroll system, and not just us, to make the world a more equitable place, what can they do in the future to make, just as we want a more sustainable world in terms of global warming, we want a more equitable world. We want a world where the business leaders are recognizing, okay, we might not be there now, but here's what we can do so that when we're answering bids in 2 years, 4 years, 5 years, we have a better response. Is there discussion that we can have with them along those lines?
Yeah, I'll just say, right, and I've been a little bit more removed. I certainly understand the importance of the issue and the importance to the board. But from the conversations that I was involved in, we certainly pressed on UKG the importance, right, for us. They introduced us to their diversity officer, right? They presented to us their diversity plan. We told them, we will help out in any way we can with their plan. If they want to try new approaches, they can come to us on that. So that's what I, had learned from the conversation. I don't know if there's more that you had learned, Jay, in your discussions with them.
No, I think we did learn a lot, and they are more conscious about, trying to expand the MWBE capabilities. Not at this time, obviously, but yes.
Yeah.
Thank you, Mitch, for the clarification. I think the way that you articulated was a lot clearer than I communicated, but that was the message. How do we convey as clear as possible that the expectations are that their firms become more inclusive of participation of disadvantaged groups and how they are planning to work towards greater participation. So thank you.
Thank you. Any other questions or comments on it? Okay, so let me then ask for a vote. Dr. Katz?
Yes.
Deputy Mayor Ann Williams, I assume?
Yes.
Thank you. Dr. Calamia?
Yes.
Dr. Martone? Dr. Morse?
Yes.
Thank you. Dr. McRae?
Yes.
Mr. Jenkins?
Yes.
Ms. Lowe?
Yes.
Bob Nolan?
Yes.
Frida Wan?
Yes.
Dr. Peña Mora?
I vote yes, but I would like to see if it is possible to put a note, at least in my vote, that it is important for us to communicate as clearly as possible our expectations and our desires that this company really look at how to enhance the participation of disadvantaged group within their business ecosystem.
Thank you. Thank you, Fenioski. Anita Kawatra?
Yes.
And Jose Pagan, yes. And just following up on the comment from Fenioski, I think it's important to give to the company this conversation that happened here, the minutes, so that they're aware that this is important to the board.
We certainly will.
And that may be the best way of conveying that information. So thank you so much. Thanks.
Thank you.
So let me move to number 8. Rita Wang, you again.
Sorry. Okay. Authorizing the New York City Health and Hospitals Corporation, the system, to increase the funding cap on the contract executed with Hunter Ambulance, which contract was assigned to American Medical Response of New York, LLC, as part of a corporate acquisition, Contractor, for a single vendor patient transportation system, such that the original spending cap of $12,070,896 be increased to an amount not to exceed $21,837,906. This was presented to Finance Committee on March 22nd, 2022, and approved to bring forth to the board. And Matt, I'll turn it over to you.
Thank you so much, Matt Siegler. I lead managed care and growth for the system. I'm joined by Caitlin Prescorn, who will take us through the presentation. Caitlin's been our operational leader on transportation throughout the entire COVID surges that we've had, along with a fantastic group of clinical partners. Caitlin really was our operational leader on each of the thousands of interfacility transfers that were so important to us and the broader New York City healthcare system in managing those very difficult levels of patient volumes during those surges. So just want to acknowledge her and introduce you all to her, and Caitlin will take us away and talk about this important contract.
Thanks, Matt. So we signed the contract with Hunter Ambulance in April of 2019. The goal around this contract was really to increase our timeliness, increase accountability, and reliability for our system transports. What we didn't know is how impactful this contract would be on our COVID level loading transfers. Hunter was able to help us facilitate over 2,000 of those transfers, balancing the system load from our hardest hit facilities to those where there was additional capacity. So from those expenses related to COVID, as well as the addition of new scopes of work, so our post-acute care facilities, our percentage of our self-pay and uninsured trips was higher than expected. We are nearing the exhaustion of our original not to exceed amount. So next slide. Hunter on average does about 40,000 annual transports for us. This number has grown year over year, resulting in an increase in our interfacility transfers that we've seen. This has also impacted the cost. As you can see on the bottom right-hand side, the blue represents the COVID-related spend, and the gray is the ambulance, and then the yellow is the smaller percentage of ambulance spend. So right now we're projecting $9.7 million in expenses above the prior estimates to cover our current spend and fund one additional year of operation. This next slide goes through the impact of the interfacility transfers. So when we compare to a year, 1 year before the contract was signed, our interfacility transfers have grown by 30%, which is 1,400 more transfers in 2021. And this obviously impacts our revenue significantly, leading to greater patient retention and reduced patients being transferred outside of the system. We've also worked very closely with the AMR and Hunter team and the Office of Quality and Safety on partnering on quality improvement activities. So how do we better use our emergent ambulance resources, dispatching those when it's most required? How do we reduce the turnaround time for the ambulance crew upon arrival to a facility so that they're able to transport that next patient faster? We've also been working closely with IT and building out integrations so that we can better capture our data and derive insights around how do we continue to streamline these processes and better utilize our resources. On the minority and women-owned business front, when we signed this contract with Hunter 3 years ago, Hunter at that time, now AMR, was granted a waiver of all MWBE goals. There's two main scopes of work for this contract. There's our ambulance transports, which includes our discharges and our interfacility transports, and our ambulette work. Currently, there are 0 minority or women-owned ambulance vendors that service the New York City area. There are, however, 4 ambulette certified minority or women-owned vendors in the New York City area. We're currently contracted, AMR is currently contracted with 1, with Covet, and that spend represents 11% of the total ambulette contract spend. Partnering with AMR, we're collaborating on an ambulette capacity development program to build out the capacity of these smaller ambulette vendors. Currently, their options and their number of staff are limited. So the goal will be to work with our vendor diversity team, with AMR, and we've started these conversations to really look at how do we help these vendors perform in the scope and be able to take on more of our volume. So focusing on building out their number of drivers and then being able to help them perform under the needs of this contract. So by the end of 2020, our goal in partnership with AMR is to increase the Ambulet contract spend for minority and women-owned businesses to 20%. So in terms of next steps, so we are asking for a 1-year extension to this contract so that we are able to release a new transportation RFP this spring. We've learned a lot under this contract. Our goal is to build out the scope further to allow us for a new emergency management scope. This will put and codify rates for us to be able to leverage those resources that were so critical for us to use during the COVID surges and have that available to us should another pandemic occur or one-off emergency situation in which that type of response is required. Also building out very specifications related to our emergent transfers. How do we continue to improve and see better performance on that front? Building out our service level agreements as well, and including penalties, and then of course adding on additional minority and women-owned commitments as a part of the next contract. We'll continue working with our quality improvement activities, and then on building out new work, leveraging livery transportation. How do we leverage livery options to improve patient retention, increase revenue, and promote linkage to appropriate settings of care? So that will also work with minority and women-owned livery vendors for that scope of work as well. So what brings us here today, we're seeking your approval to increase the not to exceed amount under this contract to $21,837,906 with AMR. Thank you.
I wanted to first again say how much we appreciate the work that you did under COVID, right? And that overshadows everything else. That you and your team saved lives by moving people under the most difficult circumstances that any of us had ever worked on. And hospitals would, sort of exhale that they could function when they were no longer overwhelmed because of the level loading that was done. So, we cannot thank you and your team. I know it's a large number of people. It's
Yes.
a large number of people at the facilities, but you bore a lot of the pressure to operationally make that happen, and we really appreciate it. On this contract extension, I think we all want to be clear that for us, this is an extension. This is not how we wish to function. We have learned, as you say, many things, and we're hoping in the next round to be able to have both better performance and a more diverse portfolio. I think echoing what Fenny talked about, and here in this case we have some time. While it's wonderful that we can make the Ambulet more diversified providers, as Matt has taught me, the real problem is that the ambulance providers, right? Because our ambulance providers will always way dwarf our need for ambulettes. I mean, that's just inherent in what we are. We are an emergency, a trauma, a hospital system. It's mostly what we're going to need are ambulance transports. What is frustrating about the current situation is the lack of a diverse group of ambulance providers. And what I would most like would be if we were going into a bid where there were where the world provided a diverse set of providers, so that when we went through the RFP, we would have a good chance that the providers would reflect the diversity of health and hospitals of New York City. In that regard, though, I wonder if we can take Fenny's very smart point and ask in the RFP, not just what are you going to do now, because there may, even in a year, unless there is a major purchase, and I know many of us are hoping for a major purchase, we're out there hoping a woman or minority-owned business will buy a ambulance provider, and that could happen. But in the absence of it happening, it seems to me that what we should be asking in the next RFP is not just what are you going to do now to increase the diversity of your ambulet, but what are you going to do to make your, as Penny would say, ecosystem more diverse? I mean, AMR and these other are, these are huge companies with, resources and capabilities that dwarf anything we could do in terms of technical assistance to growing firms. I mean, they have an opportunity to do quite a lot given their size and their capability. So I would hope that might be one of the things that could come out of a new RFP. Thank you.
Thank you. Any questions or comments, other comments from board members? Bob?
My question really is if Dr. Katz has a follow-up. Is it fair to say, because I read through this contract very quickly, that if this is really a COVID-related increase, because that's why there was a need to transfer so many people from hospital to hospital, because we were just filling up so much in one hospital and the other.
Yes.
And that the other part of this would be that not everybody is listening to our meeting today, but this is obviously an opportunity for the Economic Development Corporation of the city, if they're not doing this already, to be out there looking for people, to encourage people to step forward because there'll be a contract up for next year.
Correct.
Okay. Thank
I
you.
have two questions, Fenioski and then Michelle. Morse?
Thank you. And thank you, Dr. Katz. Again, you articulated so well what I was going to say, and I just wanted
Well,
to
you
add
taught me, Fenny.
But that's where the students surpass the master, I guess. Because you did it a lot better than I would have been able to do it. But I just want to add, like if you look at this company, AMR, and look at the different layers of ownership, because it's really convoluted, at the top of the pyramid is KKR, one of the largest global investment firms in the world. And if those individuals that have that amount of money, influence, and knowledge are not able to support a more diverse ecosystem for their companies, definitely we are for big trouble. So the message, it has to be clear to them that expectations are high. They can do it. They just need to get to it. So that's what I would like to add to Dr. Katz's comments.
Thank you. Dr. Morse?
Thank you for the presentation. And I just had a question about the patient experience side of the transfers. I think all of the data, of course, shows us that it's life-saving to do load balancing, right? That it's like critical. And, we're not expecting to not have waves of COVID anytime soon, unfortunately. So with all that considered, it's obviously critical to be able to do the load balancing that you all have done and critical for patient outcomes. But do you have any kind of qualitative information about what the patient experience of those transfers has been like, or anything you can share about that side of it?
I think I can take this one. The experience varied highly. I think the one predictor was just simply how far people were going, right? I think when transfers could be within borough, there was often, I'd say, less challenges. It wasn't always an option for us in the darkest days of COVID. But I think as with many things, and great doctors like you have taught me, so much of this is about the nature of the conversation with the patient or the family before a decision is made, right? So uniformly, on the few cases where there were negative patient experiences, it was because people were rushed and the discussion was not had with the family extensively about this is why we are doing it, this is why it's necessary, this is why you will continue to receive great care at your destination. So overall, I think people understood the need for it. It was broadly done across multiple health systems. So the patient experience overall, I think in the context of everything that was happening was good. But those were the indicators, I'd say, of when a suboptimal patient experience happened. Just not enough discussion and consultation.
Thank you. And of course, those discussions are happening often in emergencies, so I can imagine it's a challenge, but thanks.
Okay, thank you so much. Then I'm going to ask them for a vote now. Dr. Katz,
Yes.
Dr. Calamia,
Yes.
Dr. Martone.
Yes.
Thank you, Dr. Morse,
Yes.
Dr. McRae,
Yes.
Ms. Lowe,
Yes.
Mr. Nolan,
Yes.
Ms. Wang,
Yes.
Dr. Peñamora.
Yes, with the note that we should communicate as strongly as possible our expectations for them to diversify their ecosystem.
Okay, thanks. And Anita Kawatra. And Jose Pagan, yes. So thank you so much. Dr. Peñamora, you go next on number 9.
Great. Okay, I have the number 9, authorizing the New York City Health and Hospital Corporation, the system, to execute a renewal of a 5-year revocable license agreement with Consolidated Edison Company of New York, Inc., the licensee, to operate a radio communication system in approximately 50 square feet of space on the roof of the Martin Luther King Pavilion building at Harlem Hospital Center, the facility, at an annual occupancy fee of $36,295.60 to be escalated by 3% per year for a 5-year total of $192,698.27. This was presented in the Capital Committee of March 14 and was approved for consideration by the full board.
Good afternoon. Christine Flaherty, Senior Vice President, Office of Facilities Development. The background here is Con Edison has had an operating radio system on the roof of Harlem Hospital since 2002. This system provides information for Con Ed for emergencies and service operations, and it receives utility demand information to have grid awareness across a 55-mile radius. It's on the MLK roof. Next slide. This has been a system that's been in place and it has been approved by the Board of Directors in 2001, 2007, 2012, and 2019. This is a 5-year license agreement, and it's occupying approximately 50 square feet, and it will expire on April 30th of 2022. Next slide. The terms of this agreement are pretty much the same with a 3-year escalation, which includes $36,295.60 per year. It represents a 3% increase over the current occupancy fee. This isn't similar to indoor space that's occupied. It's a unique site-specific factor. So you can't use a cost per square foot market assessment, but we did confer with our real estate professionals, and this is within the market rate of similar types of equipment occupying roofs in this area. Next slide. The last slide, I believe, is the resolution that our Capital Chair Peñamora read into record. Any questions?
Thank you. Thank you so much. Yeah, any questions from board members? Hearing none, let me then ask for a vote. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Martone?
Yes.
Dr. Moore? Dr. McRae? Ms. Lowe?
Yes.
Mr. Nolan?
Yes.
Ms. Wang?
Yes.
Dr. Peñamora?
Yes.
And Jose Pagan, yes. Resolution is approved. Let's move to the next one. Dr. Peñamora, 10. Thank you so much.
Thank you. Authorizing New York City Health and Hospital Corporation, the system, to sign a 5-year revocable license agreement with Panera LLC, Panera, for the use and occupancy of approximately 3,167 square feet in 3 locations, including a basement production facility of approximately 2,341 square feet and 2 retail locations within New York City Health and Hospital Bellevue, for the operation of a restaurant at a monthly charge of $20,833.33 per month, for the first year of operation with annual increases of 2.5%, provided there shall be a 3-month abatement of the occupancy fee at the start of the agreement for a total revenue to the system of $1,251,581.93 over the 5-year term. This was discussed in the Capital Committee of March 14 and was approved for full discussion at the board.
Good afternoon. I'm joined today by our COO of Bellevue, Marcia Peters.
Hi, good afternoon. Bellevue has offered food to staff and visitors for over 30 years. Auburn Pond currently operates at Bellevue for over 10 years, offering various baked goods, soups, and salads. ABP and Panera are affiliated companies with similar operations. The proposal is for Panera to take over the ABP operations in its current footprint after modernization and rebranding the existing facilities as a Panera operation. Panera, as you stated, would occupy a total of 3,167 square feet in three locations, 2 ground floor and 1 in the basement. Panera operates at the numerous hospitals in the area and offers healthy food options, including vegan, vegetarian, and gluten-free. Panera will not increase prices above the CPI without Bellevue's approval. Next slide. Next slide, please. Oh, I missed it.
No.
Okay, thank you. Both Panera and Auburn Pond are both subsidiaries of a company based in St. Louis with over 2,000 restaurants in North America. It's privately owned by JAB, based in Germany. Panera offers 3 pricing tiers, with the hospital one being the least expensive tier. As I stated, they are in most of the greater New York metropolitan areas in various hospitals and is well known to the community. The company operates under either Auburn Pond or Panera brand, but there is an organizational shift to move some of the Auburn Pond to the Panera brand, which during taste tests are proven to be more satisfying. Next slide.
That was an image of the Panera space that will be outfitted and taking lessons learned from the high volume of occupants using the current space. This will allow more rapid pickup, which will resolve in less traffic in one tight area. So we're excited about these renovations. The next slide gives you an overview of food vendors at H&H facilities. We are working hard to make sure our facilities, especially those that aren't near a retail corridor, have easily accessible, healthy food. And this gives you a snapshot of all of the vendors, various vendors at all of the sites. We made a policy decision to install operators more as a real estate transaction for the future and focus really on having less expensive, healthy food available for our staffs when they're on breaks, as well as our visitors when they're visiting their loved ones. Also at Bellevue of note is there's the diner-style restaurant Moonstruck as well, so that there's also multiple food options for those patients, staff, and at Bellevue. Next slide. The license agreement itself has an occupancy fee of $20,833.33 per month with a 3-month abatement for the start of the license agreement so that they can do those construction improvements that were referred to. The occupancy fee will be escalated at 2.5% rate per year, and that will come to the total of $1.2 million and change. Panera is going to be responsible for cleaning, maintenance, all the regulatory filings associated with their improvement work. And this was looked at as a fair market value assessment. The occupancy fee is the market rate demonstrated a high rate at the upper level on the ground floor and a lower rate at the basement, which gives us a net effective rate of $78.93 per square foot. This is a 5-year term, but can be terminated upon 30 days notice. Last slide. We're happy now to take any questions.
Okay, so Hearing none, then let me then ask for a vote. No questions. I guess everybody likes the food choices they have in front of them. Dr. Katz,
Yes.
Dr. Calamia,
Yes.
Dr. Martone,
Yes.
Dr. Morse,
Yes.
Dr. McRae, Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Rita Wang,
Yes.
Penioski Peña Mora,
Yes.
and Jose Pagan, yes. So let's move to the next one, Dr. Peña Mora, 11.
Is 11 or am I recusing him 11 or not? Or
He's recusing.
He's recused.
11? Okay, yeah, you're recused now. Thank you so much.
yeah, I
Dr. Peña
recuse.
Mora.
Yes, that's what I want to say. Yeah, so I just want to say officially recuse. Thank you. Have a wonderful rest of the meeting. Thank you.
Thank you. Bye. Okay, so number 11, authorizing the New York City Health and Hospitals Corporation to execute a contract with Interstate Mechanical Services for an amount not to exceed $17,686,300 for construction services necessary for the replacement of the cooling tower and the upgrade of the chill tower system at NYC Health and Hospitals Bellevue Hospital Center with a 7% project contingency of $1,768,630 for unexpected changes in scope, yielding a total authorized expenditure not to exceed $19,454,930. This was presented to the Capital Committee on March 14th, 2022.
Thank you, Mr. Chairman. My name is Oscar Gonzalez, Assistant Vice President of the Office of Facilities Development. With me is Marcia Peters, Deputy Executive Director at Bellevue Hospital. And this is a request to enter into contract with Interstate Mechanical Services for Bellevue mechanical equipment. Marcia is going to give us a little background of some of the woes that we've had at Bellevue.
Hi, Bellevue's cooling towers has a capacity of 12,000 tons. We have 4 chillers with a capacity of 9,000 tons, which is located on the 23rd floor on the roof of our building and 13th floor respectively. The cooling tower has deteriorated in performance and is practically at its end of life and needs to be replaced. During the summer of 21, the heat was unbearable at Bellevue for staff, patients, and visitors. We had nearly a week's worth of canceled cases. We had to shut the OR and reorganize our schedules, and we came dangerously close to having a full diversion. New York City, next slide, please. New York City Health and Hospitals plan to replace the existing cooling towers and upgrade the chiller plant with much needed reliability and resiliency to give us the much needed reliability and resiliency in our chilled water systems operation. The overall project would include controls upgrade to existing chillers, replacement of chilled water pumps, variable frequency drives, modernization of the building's automation system, and ancillaries.
Thank you, Marcia. In order to do this work, we did a full solicitation of public bid. We received 6 bids. The lowest bidder was Interstate. They had a MWBE utilization plan of 30.45%. Next slide, please. Thank you. And right there, you will see the list of subcontractors that will be maximizing the WMBE utilization plan. The contract amount was $17,686,300. And the MWB portion of that is $5,333,725,000. This particular vendor has not done work with New York City agencies, so therefore there's no MOX evaluation. However, they have worked with NYPA, and they have recommended this particular firm to do work with us. The project is expected to complete in spring of 2023. The next slide will show you the full breakdown of the project costs. Specifically here, we're requesting for the construction cost of the $17.7 million and the project contingency of $1.7 million. And the next slide will show you the resolution.
Okay, thank you so much, Oscar. Any questions
I just clarify that Mr. Peñamora is back on? This is not a recusal for him?
Okay,
Okay.
thank you, Colicia.
Okay.
Okay, any questions on this resolution? Okay, so let me then ask for a vote. Dr. Katz,
Yes.
Dr. Calamia,
Yes.
Dr. Martone,
Yes.
Dr. Morse, Dr. McCray, Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Frida Wang,
Yes.
Benioski Peñamora,
Yes.
and Jose Pagan, yes. So thank you so much.
Thank you very much. Happy birthday,
Now I
Belgium.
formally recuse. Is that correct?
Yes, that is
Yes.
correct.
Peñamora, you can stay on. Hold on.
The next one's with the CS.
Okay, so at this moment, we don't have a quorum to continue with the two resolutions, so let me table them now. So let me move on to T2 updates. 1 second.
Yeah, Ted there, I saw him
Ted,
before.
is Ted here?
Yes, he's on.
I saw him before on the screen.
Dr. Love is on.
Ted, can you provide an update on T2 community and DOE COVID testing?
Yes, hi, I would love to.
Thank
So today I wanted to provide an update on how things have been going with respect to the vendors that we previously selected for our T2 school and community-based testing. What you can see on the slide here is a list of the vendors themselves and then the criteria or evaluation metrics that we laid out before. The way we describe it here is we look at their MWBE payments, and then we look at their current utilization, projected utilization, how close they are to achieving the goal. So I think the most important point to make here is that the vendors have actually made substantial improvements in terms of MWBE utilization. That's reflected in how much we've continued to use them or how we've made operational decisions, taking into account other factors as well, including lab turnaround time and a variety of other reliability factors in terms of how we select them for continued work. So the upshot of this is the bottom line, which is that we're on track for projected overall utilization of MWB payments for 34% of payments. So that's all on track for our goal of above 30%. The other thing I would note in this slide is that there are several vendors that have made, that are projected to make and have made substantial improvements under our guidance and prioritization of MWB payments. Next slide, please. So this goes into more detail in terms of the total tests per month, in terms of how we're using the vendors, their turnaround time, which is one of the key performance metrics we look at, and the average number of testing teams that we use for each of the different vendors. We list here BRL, MedRite, Premier, RRT, Sinai, and Somos. One thing I would note here is that overall, the turnaround time within 48 hours has been remarkable for almost all of the vendors. Many have 100. Next slide, please. And this is for our schools. So the vendors we use for our schools are BRL, Fulgent, MedRite, and Somos. And again, here you can note that the turnaround time for all these vendors has been nearly 100% for almost all of them. And we list the number of teams we have per vendor here. And again, turnaround time, MWB payments, other metrics of reliability are how we make the decision to sustain work and continue work for our different vendors. And we've seen those that have improved over time, we've given more work to them. Next slide, please. I think that's
it.
Yes,
That's
okay.
it.
Yep. And I'm happy to answer any questions. Thank you.
Thank you, Ted. Any questions from board members for Ted? Thank you for the update. Frida Wang has a
One
and
quick
then
question.
Michelle. Yes.
I I mean, it seems obvious that with what was happening in December and January, that some of the turnaround times might have been a little more challenging. Is that basically what was happening there? Because if you kind of look through, you know, the vendor performance was definitely down in those months.
Yeah, exactly. And a statistic to back that up, which I tried out myself, and I can confirm this, is that our turnaround times through PRL, Pandemic Response Lab, have improved to be 10 to 17 hours. Apologies for my sick child in the background here. But during the height of Omicron, we were doing 250,000 tests a day citywide at the peak, compared to now a steady state of more like 50, 60,000 tests. So that what you're pointing out is the key difference, yeah.
Thank you.
Okay. Dr. Morse, you have a question?
Yeah, and just another quick one. Ted, thanks for the update, and it's really impressive. I'm wondering if the federal issues around funding testing for the uninsured is impacting any of this or impacting the operations in any way?
Yeah, so just to clarify, that's a great question. So federally right now, there's the HRSA has stopped making payments for uninsured patients. That's causing a lot of the vendors across New York City to have to reevaluate their business models, and in some cases, they're wondering if they'll be able to continue to exist doing testing, which is why it's so important to hopefully have the federal government renew the funding for the uninsured, which will improve or will keep us with the high level of equity that we've had throughout testing, but also keep our overall capacity too. So what you see here, our testing sites are going to continue going to continue onwards. And we hope that if the federal government does renew their funding, it will enable us to keep the private vendors in the market as well to improve our overall capacity and our overall equity.
I think Feniowski had a question also. Feniowski?
Again, Ted, thank you. As always, it's such a good thing to hear the great things that you have accomplished during very difficult times and how you have kept always your cool. So that's always been very impressive to me, even with small children at home. So that's very nice. I just want to go back to the issue of the performance of NWBE, particularly since at the beginning when we were talking with respect to this contract, we had a particular concern with one of the firms, Fulgent, and I noticed that they exceeded the goal. I just want to thank you publicly to you, your team, as well as to Fulgent, because they did the work. And even though at the beginning they were saying that was zero, now they went to 37%. That is something that should be applauded, recognized, and celebrated. However, we do see that there are some that were not, that we were not concerned, that also are not performing at this point. Can you elaborate a little bit? What is your expectation of the performance by the end of the contract, and what steps are they taking to improve their goal attainment?
Yeah, thanks, Penny. And I just want to also thank you publicly, Penny, for always giving us guidance and pushing us to make sure that we are pushing our vendors to achieve our WB goals that we set out for them. So in particular, we've had some like Fulgent that have made tremendous progress, and that's been a great success for us. We have others that were, our goal is 30% for our vendors as we've listed it here. And for those that are close to but not exceeding or not at that goal yet, what we do is we increase the frequency of our meetings with them, we work with them, see what we can do to support them in achieving their MWBE goal. But ultimately, this is the MWBE payments is one of several important criteria that we take into account as we consider continued work. And we have adjusted work based on a variety of performance metrics, of which this is a very important one. And we'll continue to do that for the duration of our contract.
Thank you, and I have the full trust that you will communicate as clearly as possible the importance to ensure they have a diverse ecosystem to provide their services. So thank you.
Thank you, Fanny.
Thank you. Okay, any other questions? Okay, thank you, Ted. Then let me move on to the president's
you.
report. Thank you.
Very good. Well, as it has for the last 2 years, it begins with a COVID update. But really, the most astounding thing about the COVID update is that as of this morning, our 10 acute care hospitals had a total of 17 COVID patients. And I wouldn't say that all of them were in the hospital because they had COVID. So, I mean, it's pretty remarkable, the current state we're in. We're, of course, very grateful to T2 that did 10.5 million COVID tests thus far, 1.7 million vaccine doses, and we are now ready today for anyone who is over 50 and more than 4 months from their prior COVID vaccine is eligible for a second booster. And our sites are prepared to do that. There are also boosters that are now available, a second booster for people in other groups of immunodeficiency. We opened up our COVID centers of excellence. We had 1.7 million contacts through contact tracing. Our quarantine hotels are closing because they are no longer needed. But meanwhile, just some of these numbers are so amazing. We helped 33,000 people isolate in the COVID hotels that we ran. I mean, that's when you consider that no other municipality created quarantine hotels, just New York. And because of them, we had 33,000 people able to protect their families, 2.2 million free meals. I mean, these are just amazing, amazing statistics, and we're incredibly proud of it. We need to return to the other diseases that threaten people's lives, and this is Colorectal Cancer Awareness Month, and we are working collaboratively with our sister department, the Department of Health and Mental Hygiene, on making available a COVID test, colonoscopy or FIT tests for the non-invasive fecal immunochemical test to detect colon cancer. Heart disease, still a leading killer, and so we're so proud that Metropolitan was recognized within the initiative of 1 million hearts. It's a national movement. We hired Dr. Suit Teki to be the System Chief of Radiation Oncology, recognizing that that's an area where we feel we can do a better job for our patients. She's incredibly well qualified, and I think will bring a level of expertise to those services that will be welcomed by all of our clinicians and patients. The state is still working on its budget, as people are aware. We did very well in terms of earmarks in the federal budget that will help our hospitals, Queens, Jacoby, Elmhurst, and Coney Island. And in terms of our own local hearings and our own budget, we're certainly in the best position that Health and Hospitals has been in recent years. We've eliminated the almost $2 billion budget deficit. We have 42 days of cash. We no longer have a deficit. And this is not due to COVID reimbursement. If people think, oh, that's because you got your COVID dollars, that is not true. The COVID dollars that we've gotten are reimbursements that we've gotten for additional services we've provided. This is really due to our joint, including the board's efforts on direct patient care receipts. And it's ongoing dollars. It's not one-time dollars. It's not our patients paying. We're not interested in billing our patients. We're interested in getting our patients on insurance and billing their insurance correctly. We are interested in getting better rates, and we have done that. Matt's group has done that very effectively. We are interested in making sure that our clinicians are coding our patients correctly, that we are submitting prior authorizations for procedures so that they get paid, that we have business plans. And the best part is it's working. And because it's working, we are able then to focus on our mission, which will always be, what matters the most. But if you're in deficit, it's very hard to focus on mission. Then what everybody wants to know is, what are you cutting? To prevent that dynamic, you have to be able to say, we're good. And right now, we're good. I have every reason to believe that this will continue because the sources of money that we have created are all ongoing sources of money. So we'll never be rich. We will never have mauve walls in the hospital. We will never have mahogany paneling, but we will provide phenomenal care by a mission-driven set of doctors, nurses, and other health professionals. And we will welcome patients from all backgrounds and take care of them as if they're our own family. Thank you, Mr. Chair.
Thank you, Dr. Katz. Any questions from board members on the report?
Just want to say thank you, Mitch. That was a great report, and the work you've highlighted. It's been quite a 2 years, and I'm just very grateful on behalf of all of us and the city, and I know everybody on this board feels the same way. And just want to, because I have to, the financials, your explanation of it, I think, is exactly spot on, and this hasn't been done with one shots or anything like that, and it's ongoing changes to our fundamental structure and how we do things to make sure we can generate the right resources to serve our mission. And I want to also just say the work that you guys have been doing on the capital side as well is part of that, and that's really a critical component as well. So thank you.
Thank you.
Fenioski and then Dr. Calamia.
I just want to echo Frida's comment. Definitely, I really like your report, and it's not only the words or the action what is more meaningful, and you have demonstrated how much you care for the community of patients that we have and ensuring that our staff have everything that they need to deliver the best care in the world. So thank you so much.
Thank you, Feni.
Thank you, Feni. Dr. Calamia.
Yeah, I certainly want to echo that. It's just been, given the COVID situation, it's just been beyond astounding what's been accomplished with that still in the back, in the background of all of that. So it's astounding. I did have one question though about the booster, whatever we want to call it, the fourth shot, or as far as our skilled nursing facilities, our long-term care. Any thoughts on what is our policy going to be relating to that second booster?
Sure. Thanks, Vince, for raising it. And I asked Coy yesterday that exact question. Our skilled nursing facilities have the highest percentage of booster for number 3. And we will roll out this as a recommendation. As you as a physician know, this particular booster has come with more uncertainty, right? If you look at the federal authorizing language, it's much more people may get it as opposed to people should get it. And that may not be so inappropriate given the fact that we're still learning so much. But it's clear that the group at greatest risk are older people with serious comorbidity. and that's people who are living in skilled nursing facilities. So we will make it a recommendation. We've already, Dr. Allen already sent out a recommendation to our healthcare workers, recognizing that while they may not feel themselves to be at particularly high risk, that given the jobs we do, we want to do everything possible to lower the risk that we would be transmitters to anyone. Of course, we all wear masks in healthcare, but still every step makes it better. So right now we're going for this is something we recommend. That's our focus. It's not a should, but it's not just well, this is available if you want to avail yourself of it, because we think that the evidence, and I welcome your opinion and that of other healthcare professionals, we think the evidence is strong enough for us to recommend it to everyone who fits the criteria.
Yeah, I think that's exactly right, Mitch. And, the difficulty sometimes is when we recommend things, we can recommend them or we can sort of glancingly mention. So I think it's just a question, too, of the sense of our own staff and how comfortable or not they feel with the very high-risk group. Again, it's not just the aged, but the multiple comorbidities and so on, because that's the only place I think the data is somewhat strong. And I'm with you. I mean, I think particularly the Israeli data that's available, it's got a lot of questions about which groups really would benefit. But as you said, I think that group is certainly the group most likely to benefit. And again, just making sure our own providers, are of that same mind in their recommendations. So, but thank you for that. Appreciate that greatly.
Thank you.
Thank you. Any other questions or comments for Dr. Katz? Okay, so the committee report, I'll move on to the next agenda item. The committee reports were emailed to you and are in your folders for your review and submission into the record. Is there any old or new business to come before this board? Hearing none, then the board meeting is adjourned. Thank you so much. Have a great afternoon.
Thank you.
Thank you, everybody. Bye-bye.
Bye-bye.
Thank you.